Okay, we're still letting some folks in, but I'm going to go ahead and welcome everyone. Good afternoon, and welcome to today's presentation titled Meeting the Mental Health Needs of Youth Before Crisis, Utilizing Warmlines. There are a few housekeeping items I'd like to quickly go over before we begin. This presentation is being recorded, and the recording link, slides, and a letter of attendance will be sent to everyone who attended today. This information will also be available on NASHBID's and MHA's websites. Please use the chat pod to share your name and state, ask any questions, share any information with the group that pertains to the presentation. Closed captioning can be viewed by clicking the CC at the bottom of your screen or by clicking the link in the chat to view in a separate window. We also have an ASL interpreter that will be spotlit on everyone's screen. After the presentation has ended, a brief survey will show in your browser. Please take a few moments to share your comments and your thoughts about today's presentation. We would like to give a special thanks to SAMHSA for allowing us to share this information with you today. And again, thank you for joining us. I will now turn this over to Michelle Aune. Thank you.
Good afternoon, everyone. Thank you for attending. My name is Michelle Aune. I am the Executive Director for Mental Health America of Montana for 15 years now. So I've definitely seen some programs come and go. One of is our Warmline. We started with a little background of Mental Health America of Montana. We started in 1948. Group of volunteers around Montana were pretty concerned with mental health at that time, and they started a group in somebody's garage and talking about politics or policies, how Montana can help those that are struggling with mental health. In 1968, we received our nonprofit status. So we've been a very old company here in Montana. We serve the state of Montana statewide, serving adults with mental illness, disabilities, youth, other advocacies, LGBTQ plus population, as well as the indigenous peoples. Montana is the fourth largest state in the nation, has just over 1 million people. The population density in Montana is 7 people per square mile, over 147,000 square miles, making much of Montana rural and frontier. Why is this important? It's important because the vast expanse of land has limited access to healthcare and mental health services, which drive up high costs of delivery systems. We started our adult Warmline in 2008. It's called the first virtual drop-in center. So most of those that have a drop-in center in your state, we are virtual. So it's all done through the phone systems. All our responders are peers. They have lived-in experience that helps serve those that are calling in and struggling with their mental health illness. We have taken over 120,000 callers so far, with handling pre-crisis callers, finding resources such as food, clothing, therapists, counselors, jobs, unemployment issues, and housing. MHA of Montana trains all our staff, as well as bi-weekly meetings to talk about their self-care, how to handle trouble callers, and how to transfer suicide callers over to the proper channels. we believe that helping 75% of our callers that would have normally called the crisis line get to a pre-crisis level and offer additional resources so that they don't go to the emergency rooms or the hospitals. And we also take calls from all other states. Some of our callers have told us that the reason why they call in is because they either don't have a drop-in center, they can't get a hold of their therapist, their counselor, they just need to stay connected to the world, and people are just lonely. They need a sense of somebody on that phone that cares. All our callers are anonymous unless they pose a threat to themselves or to others. Then we are mandated reporters. We gather a whole bunch of different kind of data. Some of them are gender, age, what resources they need, what recovery goals they have. Do they have a therapist? Do they have a counselor? What really is their need today? And we also work on adding more options to our Warmlines, such as monthly group meetings and community events. We've been working on doing a coffee with a responder event in several different communities where people can gather together in a safe place and they can talk about their recovery. They can talk about, maybe there's a topic where are resources that they can go to. Maybe they want to talk about their self-care. Just really more on the line of what the communities have to offer and stay connected to their mental health well-being. So I am going to now turn it over to my colleague, Genea. She will finish out the rest of our slides here. So thank you.
Hi, my name is Genea Fields. I am the Program Director for Mental Health America of Montana. I manage all of our employees and our programs that we currently have going on. Unfortunately, our youth couldn't join us today, so that I am going to step in and present what they have put together for you guys today. They have established a name for their organization. They want to be called Montana Youth United. It was established in 2021. They have also put together their own mission. Their mission is to provide advocacy and education for Montana youth from Montana youth in the matters of mental health. So what do our youth do? They want to provide services to deliver adequate mental health services and resources for all of their youth. Some of the things that they would like to accomplish is they want to do a youth line. So their youth line will be youth driven and youth managed. Of course, Shelly and I will be in the background, making sure that it functions similar to our Warmline, but geared towards our youth. Another thing that they would like to do is they would love to do a summer camp. A lot of our camps here in Montana are attached to churches, so they would like to branch out of that and make sure that they offer self-care for our youth in the state. In 2019, legislation passed House Bill 583, which was amended to House Bill 589, which requires DPHHS to monitor the status of youth receiving state-funded therapeutic case management services for mental health. One of the things that they found was high-level findings, which was out-of-home mental health treatment for our youth. So 85% of our youth did not receive out-of-home mental health treatment. 12% of youth received in-state therapeutic group home, and 1% of youth received in-state acute hospitalization, psychiatric resident treatment facility, and out-of-state acute hospitalization. For all age groups, Montana has ranked in the top 5 for suicide rates in the nation for the past 45 years. In Montana, between 2011 and 2020, the youth suicide ages 11 to 17 rates is 11.9%. This is more than double the national rate for the same age group, which is 4.98%. In 2020, 62% of those youth suicides were by firearms. According to the 2021 Youth Risk Behavior Survey, during the 12 months before the survey, 10.2% of all Montana students in grades 9 through 12 had made a suicide attempt, and also 13.5% of 7th and 8th graders. The Indigenous population is at 17.6% had attempted suicide one or more times in the 12 months prior to the survey. There is a 380% increase in suicide ideations for students getting D's compared to A's. Suicide is the #1 cause of preventative death in Montana for children ages 10 to 14. Over the past 10 years, suicide is the #2 cause of death for children ages 10 to 14, adolescents ages 15 to 24, and adults ages 25 to 44. Studies show that every completed suicide, there are 6 survivors. Given there are approximately 300 suicides in Montana every year, that means that there are about 1,800 new survivors every year in Montana. So why does Montana have some of the higher suicide rates? I'm not going to go through all of these, but I'll go through some of them. Social economics plays a huge part. One to 5 Montana kids live more than 100% below the federal poverty level. Lack of behavioral health services. As you know, in Montana, we lack a lot of behavioral health services. Lack of psychiatrics, integrative behavioral health into primary care. And then alcohol as a coping strategy. Alcohol in the blood at the time of death is 2 times the national average. Here are some values of peer support programs. In a month of peer staff crisis respite use, Medicaid expenditures average $2,138 less. So peer support outperforms standard care in reducing depressive symptoms. Young people be more likely to turn to their peers before turning to professional resources. The group of youth that we have can attest to that as well, that they would prefer to reach out to their peers instead of an adult. Young people express a strong desire for peer support programs. So the direction of Montana Youth United is, our main focus right now is to get our youth line up and running. So at the top of the list is securing more funding, establish training, and then to train the staff. Long-term goals of that line is to go 24/7. And then some other goals that we have is to get those camps up and running. So we'll research, we'll make sure that we have the proper location, the proper programs, and that we're partnering with the proper organizations to offer the resources to the youth that the youth would like. Sorry. Thank you. I think I'm passing it on to Shanna. There you go.
Thank you so much. My name is Shanna Mulvihill. I'm Executive Director of Mental Health Minnesota. I've been Executive Director here since 2015. I also have a master's in counseling and have some past experience as well, responding to 988 calls about a decade ago. So before it was called 988, but that's what we all know it as, of course, now, as well as serving as a counselor for the walk-in counseling clinic here in Minneapolis. Before I keep going, I just want to echo my thanks to SAMHSA for sponsoring this webinar. I have fielded a number of inquiries about how we kind of got this started, and I think that this is a terrific option for places that are looking to initiate some version of youth peer support, because we all have the opportunity to learn from each other. And this has certainly been a learning process during this kind of pilot phase for us here at Mental Health Minnesota. So I'm going to talk about our program that we call We Can Relate, and essentially a bit about how we are using that service to respond to the mental health needs of youth with a warm line that is more dedicated strictly to teens and young adults. So with that, first, just a little bit to set the stage around how students and youth are struggling in general. So the chart on the right shows our online screening data here in Minnesota. So like many Mental Health America affiliates, we provide online mental health screenings through our website. And we have seen those absolutely skyrocket since 2019. And so you can see here that is especially the case for those who are under the age of 18, but also for those who are aged 18 to 24. Overall, I would say our screening data, one of the more surprising things about it is we have not been seeing those numbers come back down. So just to give a sense of what that context looks like, in 2019, let's say February of 19, we probably had about 400 or 500 screenings. And that was a pretty regular number for us, between 400 and 600 every month. We regularly see more than 3,000 screenings every single month now. And in fact, January was our highest month ever, which I believe was right around 3,300 screenings. About 2/3 of those are pretty consistently or under the age of 24. And so you can see that those screenings really jumped up in 2020, but have really continued to climb. We also do a student survey here in Minnesota every 3 years. And in 2022, the students who reported greater struggle, just overall greater struggles with mental health, such as depression and anxiety, than at any other time in the history of the survey. So that survey began in 1989. As I noted, it does occur every 3 years, but we've really seen a big jump, as you can see, consistently, that there are greater needs and greater identification of long-term mental health problems. The other thing I just want to point out in that chart on the right is that this isn't a brand new post-pandemic problem. And so I think very often we are looking at COVID as the instigator, if you will, of a lot of mental health concerns for youth. I think those of us who have been doing this for a while will say we saw this coming a while ago. And I just want to note, looking at the 2016 to 2019 to 2022 jumps, this has been a steady increase over time. And so, while certainly the pandemic brought a lot of these issues to the forefront and certainly worsened them in some ways, it's not a brand new problem, and therefore we can't expect that it's just going to go away as quickly as it showed up either. Just a little bit more in terms of context then, based on a couple of reports that we looked at as we started to think about what we could do in this space. There was a Healthy Mind study that collected data from 373 campuses across the country. So it was a pretty widespread data collection during the 2020 to 2021 school year. And they found that more than 60% of college students met the criteria for at least one mental health concern. There was another national survey where almost 3/4 of students reported moderate or severe psychological stress. So again, these are just things that we were looking at as we thought about what else could we do in this space. In the past, our organization had been a little more focused on serving adults. And so some of these numbers, what we were seeing in our screening data, really started to bring forward the significant needs of youth and young adults, and really spurred us to jump into taking some new steps. So the considerations that we then started to look at, kind of the what, where, and how. What do we do next? What are we doing now that maybe isn't quite enough to meet the needs of this population? So the what was essentially about the fact that peer support for youth does exist, of course, in various programs or areas of the country and within our state. But number one, there aren't enough of them. And number two, there's no real consistent offerings. And that's certainly what we found as we kind of took a look at the landscape here in our state, is that there might be something great going on in one school district or half a dozen school districts, but that's not enough. There are many students in need of peer support, and having this sort of piecemeal approach, we just felt like wasn't enough to meet the consistent needs across the board. Because we are a statewide organization, we try to make it a pretty high priority anytime we're starting something new to do our best to serve the entire state. And so it was important for us to really think about how can we offer something in terms of peer support, but be able to deliver that service statewide. But it also really needed to be manageable and low cost, because it's not like someone threw $1 million at us and said, here, go do some work for youth mental health, right? It would be great if we all had that problem. That does not tend to be the case. And so we needed to be creative and thoughtful about how we could take something like this on, how we could do more in this space, but also make sure it was manageable, and didn't mean adding a lot of staff, and we were able to keep it fairly low cost. And I'll share a little bit more about how we did that moving forward. So the other thing that we were recognizing as we talked about this is that adding texting to existing services often is the way that we try to push them out to a younger demographic. And for us, that simply hadn't increased the number of youth and young adults reaching out to us for support. And so that really prompted us to step back and kind of rethink what we were doing and say, this isn't enough. What else should and could we be doing in this space to really bridge that gap and make sure that our services were really wide open to youth and young adults who needed them. So as we dove in, we found a few things that helped inform our next steps. First, we did a number of focus groups and surveys. This actually started before the pandemic, as we were starting to recognize some additional needs by this population. But we did some of these focus groups and surveys that did show a very clear interest from students and youth in getting peer support. Certainly recognize that peers are the ones they were turning to before they would go to someone else in their life, before they would go to a therapist or someone else. But there was a real lack of formal programs available. And certainly, as I noted before, not a lot of consistency across the state in terms of their availability. So, as I just noted, those programs did really vary by school. The other thing that really varies by school and by district, and certainly by geographic area, is general availability and access to mental health support and treatment and services in general. And so in Minnesota, we are lucky to have what we call a school-linked mental health program. And that has been able to connect a lot of students to mental health treatment and services by placing community mental health providers right inside of school buildings to be able to provide those services and remove some of those barriers that might otherwise get in the way, like transportation, for example, or missing 3 hours of classwork for a 50-minute appointment, or being able to pay for it. So there's grant funding that provides kind of backup fill-in funding for anything that is not covered by insurance, for example. So those exist, but only if we have the workforce to support them, as well as the availability within the school. And so, I have friends who are school counselors who will say, yes, we have this program, it's terrific, but it generally fills up by October or November. And so if a student needs it in February or March, we're kind of stuck in a tough place. We also certainly, in Minnesota, we have a large urban area in Minneapolis and St. Paul, but also a number of very rural counties or frontier counties. And so there is a real lack of consistent access to treatment and care in those areas as well. Something else that we found, not real surprising, certainly given the teens and young adults that we were interested in reaching, but was use of technology and social media platforms was going to be essential in the success of this work. And I'll note in a few minutes a little bit about how we have been putting that into practice and will continue to build on. Another piece certainly was that anonymity and confidentiality were very important. And that was something we really heard from our focus groups and surveys of youth. And that included not always letting family or friends know about this, or really let them be aware even that they perhaps were seeking support from a service like ours. We also really found that as we talked more about providing peer support to a more specific group, that we really wanted those providing peer support to be of a similar age to the students and youth that we hope to serve. Because as many of us who have worked within the peer support world, we know that peer support really works its best if you have more in common than struggling with your mental health, but instead you also have some shared background or experience or demographics, and that can really shift peer support to really work at its very best. So taking what we had learned and considered, then we turned to what we already had and started to think through, what did we already have that we might be able to build on? So Mental Health Minnesota, very similar to Mental Health America of Montana, has run a successful Warmlines service. We've run ours since 2015. And so we respond to, at this point, to about 15,000 calls, texts, and chats every year. We'll have responded to about 100,000 total by the end of 2023. Now, 1 in 4 of those who reach out to our Warmline service do tell us that they would use crisis services or 911 or go to an emergency department if they weren't able to reach us. That being said, we only hand off about 1% of our calls to that level of service. And so it was really a well-documented, successful service that we were already providing. But as I said, we added chat to that service in 2017, and we didn't see a lot of shift in terms of a lot of youth or young people using that service. So we were also utilizing a short code texting service, a cloud-based phone service, and online chat service for other programs. So we could add lines to those as needed. So we had the infrastructure in place that we needed to be able to deliver a new service. So we were able to kind of build and layer upon what we already had. We also had the policies and procedures in place that were needed for this type of service. And so, just a few examples here: confidentiality policies, social media use in terms of what we talk about outside of the organization, crisis intervention and active rescue, reporting of maltreatment and abuse. So we had a lot of those pieces in place as well to be able to more quickly launch something rather than trying to start from scratch. We also have what we kind of refer to as next level help available as backup to our services. And we do that in a couple of different ways. First, we are able to provide a warm handoff if needed to crisis services. So in Minnesota, we do have county crisis services that are tied to our mobile crisis teams. Those are available statewide 24/7. And so we are able to work with people if they need that next level of crisis intervention, and potentially even someone coming out to them, to be able to hand them off as needed to get that level of service. And we also, if someone's texting or chatting, we can kind of initiate shifting that to a phone call so that we're able to connect with the person a bit more and then do that direct handoff. I really feel strongly, frankly, in this arena, that as much as possible for us to only have people have to make one call is so important, because it can be really difficult to make that first one. And so as much as possible, we try to make it a very smooth transition for folks who reach out to us for whatever it is they're looking for, and whether it's a handoff within our own organization to different levels of service, or if it's a handoff outside of our organization to the right option. I do think that that's so important. One of the things that we've done to underline that has been to make it as easy as possible for folks to reach someone else if we are not available or if it's outside our operating hours. So our Warmline, for example, is open 7 days a week, 9 a.m. to 9 p.m. So it's not a 24/7 service, but we know that 988 is. And so if someone calls our Warmline and it's outside of the operating hours, they get a message that says, thank you so much for calling. We know what our open hours are, but then we also say, if you'd like to talk with someone right away, you can talk with 988 crisis response just by pressing 1. Because we just want to make it as easy as possible for people to connect with someone if that's really what they need. So to take some initial steps toward supporting youth and young adults, we decided to start with 2 things. So the first one was building an opportunity for teens and young adults to access peer support, regardless of where they attend school or whether they attend school at all. And so it couldn't just be about a connection with the K-12 system or with universities or colleges. We wanted it to be broader than that, because that didn't capture everyone who might be looking for that service and support. The second piece that we wanted to dive into was promoting provision of more informal support in schools, and as well as connections to resources. So I'll talk a little bit more now about how we've been jumping into those 2 things. So first, we initiated a new branch, if you will, of the Minnesota Warmline. So we started that by kicking it off in May of 2022 with this new branch or division of our Warmline service. We called it We Can Relate, and really promoted it as a free and anonymous online peer support for teens and young adults. So the We Can Relate service does provide peer support to teens and young adults who are struggling with their mental health. As I noted, it's really built on top of an already successful Warmline service. And it was actually developed as part of a social work internship, and is currently being staffed by volunteers. So that meant our cost to sort of jumpstart it and pilot this work was pretty minimal, and allowed us to jump into it a little bit earlier than we would have been able to do if we had to wait to seek and solidify funding. So as of now, the service is delivered exclusively via online chat. So that is something that we heard from the students in our focus groups in terms of their preferred channel of communication. And because it had been sort of our assumption walking into it was maybe we need to just sort of brand the texting differently within our Warmline. And one of the things that we heard from the students we talked to was, but if I text, my parents see it. My parents see that the numbers I'm texting to on my bill or on the phone records. As a parent myself, I found that slightly alarming because I want to know what's happening in my kids' lives. That being said, if that's reality, that's reality. And we wanted to make sure that we were reflecting that. And so we started just with online chat. As we're kind of starting to move forward, we may look at adding some of these other channels as possibilities, just to be as open and accessible as possible. So the online chat is accessed directly through our website, which has been designed to be very simple and mobile friendly. And in fact, right from a mobile device on our website, the chat button just pops up right at the very bottom, and you can just click on that and then touch, what it is that you're looking for. Are you looking for information on referrals? Are you looking for peer support? Are you looking for peer support for youth, etc. So we're also creating some new and easier ways to be able to connect as well, more directly through social media channels. And so we are digging more deeply into our Instagram and Facebook accounts and a Tumblr and through Apple Messenger to make it very easy to connect directly through some of the posts that we put out there about this kind of service. So as I noted, peer support really works its best when you have more in common than struggling with your mental health, but you also have some level of similar life experience. And so the We Can Relate service is staffed by trained volunteers who are young adults, age 18 to 25, who have also faced their own mental health concerns and can kind of quote unquote relate to what teens and young adults are currently going through. So our volunteers complete right around 30 hours of training in a variety of topics, including provision of peer support, the question, persuade, refer, or known as QPR, access to lethal means, suicide risk assessment and safety assessment, safety planning, kind of an introduction to motivational interviewing, as well as trauma-informed care, boundaries, ethics, cultural competence and humility, as well as some specific challenges that youth and young adults tend to face. As of now, as we started it, we had pretty limited hours. So we started it just being open Monday through Thursday, 3 p.m. to 9 p.m., sort of these after school hours. It is our hope that we'll be able to expand those hours to 7 days a week by this summer. As I noted, we've really been in pilot phase, if you will, for all of 22. And so now we're really in kind of next stage planning phase of really starting to build this out. We also have some additional funds that have come in to be available to help us staff that program. And so we'll use those funds to expand those hours, perhaps pay staff instead of having it exclusively be volunteers and promote that service. We're finalizing how we want to use those funds, as well as the possibility of providing stipends perhaps to interns or volunteers to staff that service moving forward rather than depending exclusively on unpaid volunteers for it. Wanted to talk a little bit about some of the challenges we've encountered, because those are a very real part of developing anything new, as we all know. Certainly financial support, as we know, is always a challenge. And so making sure that we're able to if we start to be able, or we start to pay staff, that we have a plan for long-term sustainability for that. So we are seeking additional funding streams.
And Shanna, I believe your connection may be frozen. And team, if someone wants to jump in here, or we can move on to the next topic until we can get Shanna reconnected.
Yeah, I have quite a few questions that have come in, so we can do a few questions in the meantime until we can get Shanna reconnected. If we still have our other speakers on, either of you can answer a few of these for our audience. First, just thank you so much, everyone, for your participation and all of your wonderful questions. There have been so many good ones coming in. One question that has come up quite often is the interest in how to find the youth to become peer support workers, what kind of trainings you're putting them through. I know Shanna started to talk about hers, but at MHA Montana, if you want to share how you train your peer support workers, what are kind of the estimated age ranges of those youth, and what do you look for in those type of individuals?
Sure. I will jump in, and if Genea, if you have anything. Right now, we will be putting, we're pretty close to turning on our line. We will start with 18 and up. 18 to 26 is really what we are envisioning. However, those that are younger than 18 will be placed on the board so that they get that mentoring and kind of the backdrop of what it is to run a nonprofit organization, and how to manage the line so that they are ready and they're ready to jump on the line when they turn 18. Most of all, our Warmline responders, as well as our youth, have lived experience. They've have some struggles and some challenges, and we like that just because it gives that balance to when they're reaching out to another peer, that they have that kind of experience behind them, and that they could share that that balance with that peer that is struggling. Right now, we are looking at different types of training programs so that they get the full support and the proper training to handle calls that do come in. I do want to remind everybody that we will not be a crisis line. So it's really, and I do know that we do take some of those calls already on our warm line, our adult warm line. But I kind of feel like we're not in that stage yet. So we do have some other training materials that we will be adding to their schedule. We have our own training slides, and then some other trainings like QPR Assist and some other online trainings that we will get them to do. In Montana, we have our peer support specialists bill that is kind of being yanked all over the place. So we're just waiting until the session ends to see where and what that lies for our kids that turn 18 and what kind of requirements are going to be added to in order for them to be on our line.
Thank you, Michelle. Kind of going along that line, another question that came through about those that are providing the peer support. How do you address peer support burnout, or is that included in your training for those youth that are engaging in peer support? Just as we see counselors and clinicians take on some of those harder emotions with these types of conversations, I know it's probably just as applicable in these settings as well. I'm just curious as to if you've seen that or if you're addressing that in any of your training.
We've dealt with burnout, of course, on our adult warm line. It does get covered in our trainings that we provide to all of our staff. It doesn't happen frequently, but it does happen from time to time. The hours given to each employee is very limited. Nobody is working full-time on the line just specifically for this burnout. Sometimes people need to take a step away for a hot minute, whether that's just a few days, a week or so, depending on the situation. But our staff does a really good job verbalizing their self-care and what they need from us in order to keep going.
Wonderful. That's great to hear that you're able to provide that support for them too and have that kind of open environment. I think we have Shanna back on. So Shanna, if you wanted to jump back in, we'll have you wrap up your slides and then we'll have some time to go through more of these questions that you all sent in.
Great, thank you, Jackie. I have absolutely no idea what may have happened there. I have faster internet here at my office than I've ever had in my life, so I don't know what's going on there, but I'm sorry about that. I will jump back into this, the challenges slide, and just say a little bit more about that. So volunteers versus paid staff, of course, you know, we all have volunteers who are dedicated and faithfully show up for every shift. But there is also, you know, a lot of staff work involved with that to be able to recruit and train and schedule volunteers that is different from staff as well. Training and education, we've been retooling our training plan a bit, simply based on feedback that we've gotten from current volunteers about some additional things perhaps we might want to include. The fact that we've seen the interactions look a little bit different sometimes than our adult warm line, and so that has made it important for us to just consider where else we could add some additional training. Demonstrating impact for anonymous services is always a big challenge, and so that's something that we experience in a lot of our services, because anonymity is really an important piece of what we do. And yet that means we can't really track someone down to see how they're doing. Now, that being said, we are considering offering follow-up outreach for this program in particular, more similar to the way that we'll be operating our new 988 Lifeline Center that we are getting up and running here in Minnesota as well. You know, as I mentioned, there is continued and consistent availability of other services, which does make it a little bit challenging to make referrals to treatment or services when you're a statewide organization, because there's just the same things aren't available everywhere, and some things aren't very available at all. And so those are consideration that we've had to really consider and really think about how to handle that moving forward. There are certainly unique challenges to serving youth as well, and I would note specifically, for example, reporting of abuse that has a different feel and a different threshold when it comes to a minor than it does around an adult. And so those are things that we've needed to shift and make some changes to our policies over time to make sure that we were getting this right. We've also really recognized that our interactions with teens and young adults through this service of We Can Relate tend to be of higher level of intensity than our Warmline service. Now, overall, we've really seen the level of intensity of our Warmline interactions increase quite a bit over the last few years, really just since the pandemic. But we've really noticed that this service in particular that's more dedicated to teens and young adults does tend to have a higher level of intensity from the start. And frankly, I would attribute much of that to the fact that, of course, often teens and youth simply haven't yet had the time needed to develop the coping skills and resiliency that we perhaps have often developed as adults. So overall, while I note this as challenges, I kind of see it as a roadmap for what's next as we move past a pilot stage and really continue to build out this service. I wanted to just highlight a little bit about how we're promoting it. So on the left, you see a poster that we put together that we put up in schools. We also have created these small little cards, and that's how we promote most of our services, is essentially these business card sized little cards with information, trying to keep it simple and small, so it's something that someone can pick up at a table that also doesn't scream "I need help," but instead is just has kind of a simple laid back look to it, as well as the QR code to directly connect someone with our website so they can access the service. It also, we wanted the card to also highlight the fact that there are other things that people can do on our website, like resources and tools, our online mental health screenings, referrals to treatment and services, certainly the peer support piece, connections to 988 or crisis. We recently added interactive tools to our website to allow people to build their own safety plan and wellness plan to download or send to themselves or others. So really see this as an opportunity, not just to promote this service in particular, but all of the things that we can offer to youth and young adults. This is just an example of some tabling that we did. So this was actually at a school behavioral health conference in Minnesota here last fall. And so just an example of how we try to set up our information so that it really feels like a safe and welcoming place to be. And to do that, we have decided to start playing Plinko at our table. And what you see on the right are magnets that we give away as part of Plinko. And so there are 5 spots you can land on. When you put the little Plinko coin up at the top for our mental health Plinko game, and then whichever one it lands on, whether it's you are strong, you are brave, you are resilient, you are loved, you are enough, that's the magnet that you get. And it has been a fascinating thing to watch people interact with this game and our organization as a result, because someone will start playing, the little Plinko game and put the tab up there, and it comes down and it lands. They're like, yeah, I am brave. And it's just, this interaction has been really fascinating. And so we've actually been sending some of the magnets out to teachers as well, for them to give out to students, to be able to just connect them with feelings of resiliency and care and support. The kind of part 2 that we had identified was trying to find ways to create environments in our schools where students felt that there were people that they could reach out to and connect with. So maybe that's other students, but maybe that's teachers or counselors or other trusted adults. And so we created this campaign we called "I'm Here to Listen." And the goal of that was really to create these simple stickers that you can see here with the design to foster an environment within schools that really allows students to feel more comfortable in opening up about their mental health. And so, we say, put the sticker anywhere, right? Classroom doors, whiteboards, lockers, laptops, water bottles, anywhere a student might be able to clearly see it. And our hope is really to start those conversations and decrease stigma surrounding mental health by helping identify students and teachers and staff who are just willing to listen and provide support. Not that they have to have all the answers. And in fact, sometimes it's best not to. Sometimes you just need a listening ear and not a problem solver. Alongside those stickers, then we created posters to put up in schools, just sort of explaining what the stickers were all about, as well as just small 4x6 cards that go with the stickers to be able to provide some tips on how to help and different resources to provide. And so the resources we identified, we tried to keep it simple. And so, certainly referring back to the services we ourselves provide as an organization, as well as the 988 Suicide and Crisis Lifeline, and then noted counseling and therapy. So, just noting that there are other options with perhaps even within the school to connect with school counseling or mental health services to get a student to that next step if they really needed that. And with that was the end of my slides. So thank you for letting me finish and certainly happy to jump into the Q&A.
Wonderful. Thank you so much, Shanna. And thank you, everyone, just again, for all of the wonderful questions. We really appreciate them. I've collected quite a few that we'll try and get through now, and feel free for anyone to hop in and answer any of these. The first one that I'd love to go through, someone had asked early on in the presentation, is how you're determining the success of your programs, what kind of data you might be collecting from these Warmlines, and how you're reporting on them.
Well, I'm happy to jump in on that one. I would say the primary, there's a few different data points that I would say that we use. Now, because the service is anonymous in nature, we really try to limit what we ask of those who reach out to our Warmline service to really create an opportunity for them to just get some support without having to tell us that much about themselves. But we do ask about what they would do if they couldn't reach us. And I noted that statistic earlier that about 1 in 4 tell us that they would use crisis services or contact 911 or perhaps even go to an emergency department. And yet, if 25% of our callers are telling us that, but we're only actually connecting about 1% of those 15,000 calls we take a year to that level of service, that's a huge success. And it's a success in many different ways, right? It's a success for the individual, because nobody should go to an ER if they don't need an ER, right? And so if we're able to connect someone with support, that's been so critical. We also ask our peer support counselors to do a little bit of feedback as part of our forms as well. And so they will look at, they will identify kind of that level of intensity, 1 to 10. We have a scale around what level of intensity each individual contact was. And that's where I think I noted earlier, we've really seen a shift from kind of an average of a 3 or a 4 up to like a 6 or a 7 during the pandemic, and really since then, as a lot of folks have been very isolated. We also ask our counselors to assess whether or not someone seemed calmer, and that what they were experiencing had the intensity level of that had gone down during the call, and that happens in about 96% of our calls. So those are some of the things that we that we track in terms of data to really demonstrate success, despite the fact that we don't ask people a lot of information or do follow up.
I want to jump in here because we also we collect a lot of data as well, and we ask whether or not they have been in touch with the 988, should they be going through a crisis. Sometimes we have the crisis centers transfer some of those callers directly to us because they're not in a crisis, but they do need to talk to somebody. So we do collect all that data, as well as, do they have a support system? Do they have family? Do they have a counselor? Do they have a therapist? And how they were feeling at the beginning of the call, how they were feeling at the end of the call, and if this truly helped them from going into a crisis. And yeah, I want to say, even with the presentation that we did, more than 75% of our callers did find that calling the warm line was very helpful and prevented them from going into a crisis. So we too get that kind of data, and I think it really shows when preventative services, that we think that that's where we are versus the crisis service, and we need more preventative service, obviously, especially since the pandemic has hit, because we have gone from having maybe 8,000 to 10,000 calls a year to over 22,000 callers in a given year now. So it's.
Jackie, if you don't mind, I just want to jump on something that Michelle had mentioned there, and that is, when she noted that she'll have crisis services hand callers off to the warm line. And I just want to call that out because that's something that we've really worked hard to do too, as we built relationships with crisis providers. And I noted, our ability to kind of hand up, but I think often in this sector, we don't have a tendency to hand down. And so it's always kind of escalating a person to that next level of crisis, rather than looking at what they really need in that moment and getting them to that place. And so, Michelle, you did a great job of noting this is about prevention. It's about, before a person gets to a point of crisis, ideally, there are folks who contact us every day. And that's okay. This is what helps keep them out of the hospital. It helps them maintain their wellness. It helps them be independent, all of those things. But there's not as much of a tendency to hand back and forth, I think, as much as we'd like. And I just really like to look at this work as this should be a no wrong door approach, right? No matter where someone calls, let's do our best to work together to get them connected in with what would really help them the very most in that moment.
Absolutely. Thank you both, Shelley and Shanna, for bringing up that point. It is so important when we're thinking about all of these services that are available and really being able to connect individuals to the service that they need most and that meets their needs at that time. So thank you for bringing that up. Another question that I'll have you address, I know that Shanna, you had kind of mentioned that Mental Health Minnesota serves different populations, but how do you see these types of programs working differently in rural versus urban areas? And what are some of the challenges you've had to address there?
Well, I'm happy to start, and then Michelle, I'm sure you have something to offer on this as well, given the large rural population Montana serves too. But I would say probably the biggest thing I would point to is just access to care and treatment, because in a lot of rural areas that's hard to find. And so that's something that, you mentioned, Jackie, that we have a variety of different services. one of the things that, perhaps if someone reaches out to our helpline, for example, and is looking for referrals to treatment or services, we'll work through some of that with them. But then we also talk about setting expectations, right, around how long it might take or availability of providers. And then just know, like, hey, our Warmlines open 12 hours a day. And in fact, they're open right now. Can I hand out, can I transfer you over there and you can talk with them a little bit? You can call them every day if you want to kind of get you through until you're able to get in to see someone. And so that's been really, really critical, I think, in terms of being able to help people bridge that gap between when they're recognizing that they need some help and when they can actually get it. Because unfortunately in this sector, that's not as immediate as we'd like it to be. But I would say, in terms of rural versus urban, that's probably one of the key call outs that I would say is just, that someone's not able to get access to other types of treatment and services. And so they may depend perhaps more heavily on services like our Warmlines to be able to get them through day to day. And there might be a long stretch before they can get something else.
No, exactly. We mirror the same thing, definitely bridge the gaps. And if we have a caller that needs to find a therapist because they're in a rural area, we do search high and low because we have a very limited access to where providers are. They're not likely in rural areas. And I know for one, we have a rural area that has to travel 5 hours away just to get medical care. So our Warmline is kind of their Warmline, their line, their lifeline until they can get in to see somebody or find somebody, or and it just doesn't start and end with just a therapist. It's about food, it's about a job, it's about clothing, it's about getting groceries, it's about, it's everything under the sun. So I believe that our Warmline does provide all that and help each caller get to the needs of what is that need that they need, what is that for today, and then tomorrow, let's talk tomorrow, let's kind of work on that. We really try to gear onto that recovery goals. So we really try to help them with, what are your goals? Maybe we don't do 3 months, maybe we just do a couple weeks at a time, so that we can get those little baby steps into big baby steps, so that they're functioning and they're getting the needs and the services that they need. Unfortunately, Montana it's just limited here in Montana, and it's a shame, but it's just where we are at the moment.
Yeah, absolutely. Thank you, Shelley, and thank you, Shanna. I know there were multiple comments from different individuals in the chat asking about, what the clinical care options look like in your area, and if those are limited. And I'm sure they are, as they are in many areas, even urban areas. People are on long waiting lists to get in to see someone, especially youth, and in our rural areas, even more so when the options are so limited. So thank you for addressing that. Another question that came through was, if your peer counselors have a client list that they stay in contact with, or is it random each time a person is calling? Talking about kind of how you can build up relationships through these calls, and are they able to connect with the same individuals regularly, or are they handed off, and how that's handled?
I know for us, go ahead, Genea.
For us, our line is pretty anonymous. Our schedules aren't given out. We're we're not necessarily here to build relationships with individuals. We're here to help them through what they're going through today. So we do have a lot of regular callers who do call on a regular basis. And sometimes it's just to check in. Sometimes it's to need more resources. But we're not here to call them back. So it's anonymous going both ways, anonymous for us and anonymous for them as well. So we don't do the callbacks, but just like Minnesota is thinking of putting that into their program as well, we're also thinking of how can we establish some sort of callback system, and what does that look like for us and for the callers, because safety is number one for us. So that's where we're at.
Yeah, and boundaries are also a high priority to think about, is boundaries, and everybody likes to not follow them, but but lately we have been seeing a high call, and that should we do call back a client, we don't really call them our clients, they're just our callers. But if we do, we would need the permission from the caller to call back, just to see, did they get the resource that they needed, and what kind of follow-up, because that's another thing here in Montana that doesn't do, is that whole follow-up. That whole follow-up is huge and very important to have. Did you get it? And what is that next step that we need to help you with?
Well, I'm happy to jump in here too, Jackie, and it's a pretty similar response to what you already heard, but we do treat each call as an individual interaction, and whoever picks up is who picks up. And so we've got 4 staff working at a time, responding to calls or texts or chats, as well as a supervisor on duty. And so, the calls just ring in to whoever was on the call the least recently, and that's who picks up. And the other thing I guess I would note is, this is, because these are individual interactions, it's not case management. We don't share information that we learn on the call with other staff. If a staff member needs to kind of process a call, they may do that with a supervisor, but we don't share things that we learn from a caller with other staff, because that pulls away that anonymity, right? And so we're also not documenting any of it. We don't have case notes. We don't have any of those things, we document some of the things that we want to know in terms of level of intensity, and were they doing better at the end than they were at the beginning, some of that, county of residence, a few things like that, but we're not, nothing that we document about any of our Warmline or relay calls is directly attributable to any individual. So there's no identifiable data in any of it. So we're not tracking people over time in any way. We get to know people a little bit. We do have folks, who do call us every day, or pretty frequently, but every single time they call us is treated as an individual interaction, not just like kind of one more entry in a record or anything.
Yeah, absolutely. Thank you for that. And thanks for addressing, the importance of boundaries in these types of settings as well. I know we had a few questions when you were discussing, and I think it was during Shanna's part of the presentation, about, the involvement of parents in this, and how do we keep the safety of youth in mind and protect them, but also as a parent, wanting to know what's going on in your child's life and being there for them. Someone had asked, are there times when you do get parents involved, or when would be the point when you would refer out, and how to handle those types of situations?
Well, I mean, since it came up when I was speaking, I'm happy to go first anyway. And I would say, it's really, with all of our call lines, and so whether that's We Can Relate or the Warmline or our helpline, or we're in the midst of standing up a new 988 Lifeline center here in Minnesota as well. the piece that's really critical for us is to collaborate with the person to every extent possible. If they need some additional help, or if we feel like perhaps a connection in their life would be like a parent would be a good one to make. And so those are conversations that we will introduce as part of that interaction. So whether it's chat or text or call, is this something, is there anyone in your life you can talk to about this? If it's a teen or a youth, have you talked with anybody in your family about this? Because or any of your family or friends. There are a lot of complex relationships, right? And parents aren't necessarily perhaps the most trusted resource for every single youth out there either. And so we want to be cognizant of that and keep those questions as open as possible as we kind of drill down to what kind of support system someone has and how we might be able to be helpful in connecting them more closely to that if they're having a pretty critical need right now. And so, if we're talking with a 13-year-old and we're getting concerned about their safety, is there anybody else in your home right now with you? Who else could you connect with right now? Do you want to go get them while we continue to talk more about what's happening? Some of that. So it's still, the ball is still in their court, if you will. But we bring in those conversations to make sure that we are really stressing the importance of not just this solitary interaction with a counselor, but also longer term, both short term and long term, who else is in their life that can provide that help or support.
Yeah, absolutely. We don't have our youth lineup yet, but we have been receiving calls on our Warmline, and they're not as dire crisis, but definitely have, as we move forward to research and listen to the youth, what is that criteria that we need to stand by, especially with support? Maybe it's not a parent, maybe it's an aunt, maybe it's uncle, who is that support person? So we definitely will be incorporating all that into our youth line as we move forward. So.
Absolutely. Thank you both. We've had quite a few people asking about the expansion of your services and your reach. And I just want to confirm with each of you, if you're serving your entire state at the moment, or how broad your reach goes, and do you accept callers from outside areas, or if you're having callers that aren't within the areas that you're serving, are you able to then pass them on to more national call lines or things like that?
We do. We are statewide. So we reach from east to west to north to south. And we do get callers from out of state. And we do, what we do is we just research and make sure what is that need of that caller, what are they looking for? And they don't really necessarily have to tell us the address that they're living in, but maybe the county, so that we can research of what kind of resources are around, what you need, how you can get a hold of them. So we do that. But there isn't any kind of scope for us to not take these callers. In fact, one of our other affiliates will transfer all their out-of-state callers directly to us, to the Warmline. So, I think that in the world today that we're living in right now, we still need to take those callers, whether they're in state or out of state, because people are looking for help, and people need to have that social interaction to just talk to somebody. And that's what we'll do and we'll continue to do.
Well, Mental Health Minnesota is also a statewide organization, and so we serve all 87 counties here in our state, as well as a number of tribal nations. Um, we 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 try to focus on callers in state simply because there's already a lot of those, and so we do try to limit that scope. That being said, if someone calls us from out of state, it's not like we hang up on them. We'll talk with them a little bit and then try to find them a resource that is within their state. It's one of the wonderful things about being part of a very large affiliate network as part of Mental Health America as well, is that is certainly a network that we can depend on to be able to convey to someone in terms of a more local connection to something that's closer to them. It might be more helpful.
And I just want to step in real fast and say, some of our Warmlines have gone down from other states. Even some mental health centers have gone down. So I think those individuals that reach out to us are kind of some of those cases where they don't have that kind of support to just call in, and maybe their support line isn't available, so they call us, and that's okay.
Yeah.
We're okay with that.
Yeah, well, thank you both. There's definitely never too many resources and people are always looking for help. So it's nice to hear that you are able to meet those callers that are calling in even from different areas and help direct them to services. I know we're getting close to our time here, but I'd love to do one more question. And this is kind of an all-encompassing from multiple questions I've seen come through, but a lot of people are interested in getting started, or they might have a Warmline in their area and they're looking to advance or further it. What are some of the most important considerations or advice you could provide those with that are either working to get a Warmline up and running in their area or looking to further theirs? And specifically, people have been asking too about how you found the funding for these types of programs.
Wow, that's a big question. As far as the funding, we started with the state. They had, when the drop-in centers started, that's when we started, we put in our proposal, but we wanted to offer a different kind of service, which was just virtual. And that was, people can call in versus coming into the center. We know that we have those individuals that rather speak on the phone and get that kind of service versus getting into a center, coming into the center and going through their program. So that's how we got started. We started with the state. I can say that we are no longer funded with the state. So we've had to find other ways of funding, which is private funding or fundraising, or and especially as we move forward to do our youth line, it's getting the youth involved. It's getting, your employees involved to, sit down and say, what is that need? What is it that, our mission, what is it that we could do? And that's exactly what we did. We sat down and we spoke to the youth. What do we need to do? And they're really heavily involved in doing fundraising and going and doing events to talk at community events, and going throughout the state to talk to other organizations. This is how we want you to support us. And so that's how we're getting started with our youth line. Our adult Warmline has already been running for almost 15 years now. So we have exactly what we want to do, and adding services, adding more services to your program. So for us to go out into the community and have an event, talk to the communities on different topics, your self-care, your, where is your recovery goal? What is it that you want to do? How do you want to, do you want to move? Do you want to get a different job? So it's having that conversation, getting that conversation going so that everybody has their needs taken care of, and the understanding of what more is needed in the community. So that's how we've done it.
Thanks, Shelley.
And in Minnesota, I've actually been working with a number of states over the last year or so to help them stand up Warmlines as well. So I think there is growing interest, as well as I think just overall recognition of the importance of this type of service, and real interest in building it. So just a few things I guess I would note in terms of getting started. Is one, kind of defining your space. That's been particularly useful for us as we really build ourselves out as a trusted partner and provider to other mental health providers and services, is that we know where we should be operating. We're not crisis providers. We're not doing full assessments. We're not, all of those things. We're not doing that as part of this service. We are here to provide peer support. And if someone needs something more than that, then we're going to help them connect in with that, not try to do it ourselves. And that's been really critical to being able to really, really build that trust with providers, that we know what we're doing, but we're going to operate within our space and our level of expertise. Tied to that then is then building out the policies and procedures that support that, and trying to get in front of those as much as possible. I felt like the first 2 or 3 years of us, at least the first 2 years of us running our Warmline, we were constantly trying to catch up, right? Of like, oh, this came up, we need a policy around this. Oh, there's this. We really need to make sure we are addressing that as well. And so, trying to get in front of that as much as possible, I think, is also important. And the third piece I would note is think about how to collect data that is useful, but don't over collect data. And that's tricky sometimes to find that sweet spot in data collection. But because these services are really largely intended to be anonymous in nature, they're free of charge, so there's no billable option, all of those things. It's important that we know that any data we collect or track, we're actually going to use for something, right? It's not just like, oh, just in case we might want it someday, but instead there's real intention behind every piece of data that we collect, or I ask my staff to document. And frankly, because there are times when our call queue is 5 or 6 people deep, and every minute they spend on filling out a form is a minute they're not answering a call. And so we want to be really, really thoughtful about that. I think the data collection then leads to how we've been able to fund the service over time. I noted that we asked people what they would do if they couldn't reach us, and that a pretty high number are going to use some of these higher level, more intensive, and frankly, more expensive services. And so having that information combined with their county of residence and their insurance carrier has helped us knock on doors of counties and insurance providers in terms of really kind of making the case for cost avoidance that this type of service provides. And so, I think a lot of states are in a similar position to the one you identified, Michelle, where there's little or no state funding available for this type of service. And so we have had to look elsewhere because it's also not billable, right, when it's anonymous. And so we have to get creative and kind of cobble this stuff together. It's my hope that as we continue to really demonstrate the impact of this kind of work, it'll be easier for us to continue to build out funding streams for it.
Thank you so much, Shanna, and thank you, Shelley and Genea. I know we're right at the hour, and I just want to say thank you so much to each of you and the knowledge that you've shared with us today. I'll hand it back over to Kelly as she has a few wrapping up remarks for us.
Thank you, Jackie, and thank you so much to our speakers, and thank you all for joining us, and special thanks to SAMHSA for allowing us to share this information with you today. The recording link, the slides, and a letter of attendance will be sent to you via email within a few days. Enjoy the rest of your afternoon. Take care, everybody. Bye-bye.
Thank you. That does conclude today's meeting. You may now disconnect.